Herkese merhabalar. Bugün konuğumuz Texas Üniversitesi Diyabet Araştırmaları Merkezi'nden Profesör Doktor Muhammed Abdul-Ghani. Muhammed Abdul-Ghani dünyada diyabet alanında en önemli 3-5 isimden bir tanesi. Şimdi özellikle son zamanlarda artan GLP-1 bazlı tedavi, özellikle kilo verdirici ilaçlar olarak bildiğimiz haftalık enjeksiyonlarla ilgili kendisine sorular sorup bu konudaki düşüncelerini almak istiyorum. Professor Muhammed Abdul-Ghani, first of all, I would like to thank for your joining us today.
My pleasure.
As you know, GLP-1 based therapy are game changer at the moment in the field of diabetes as well as obesity. We are excited to hear your thoughts and insight regarding this evolving area. In recent years, let's start with this question. In recent years, GLP-1 based treatment have become very popular all over the world. Why do you think these medications are attracting so much attention today?
Yeah, I think the most reason, there are two different things. Specifically to your question, what makes those drugs attractive to the public is the fact that they cause a weight loss. And if you look into the Semaglutide, which is the Ozempic, and the Tirzepatide, the Mounjaro, they cause the most weight loss, and that's what drove the sales for these two drugs so high. Just to give you an example, in 2025, the annual sales of Mounjaro was over $35 billion, and same thing for the Ozempic and the Wegovy. But let's remember, those drugs were invented to treat diabetes.
Right.
And they're indeed very good in treating people with diabetes because they influence the basic mechanism which is defected in people with diabetes, and that is the impairment in beta cell function, the inability of the pancreas to secrete enough insulin.
Right.
And this is why I think for people who have diabetes, type 2 diabetes we are talking, I think everybody should be on this medication, because what this medication does, no other medication does the function that this medication does. Now, the fact that this medication produces weight loss, that's additional benefit for the diabetic patients. But that's not the primary purpose from which those medications were developed. Now, the question is, if somebody doesn't have diabetes, but he's already obese, whether to recommend for him using those medications, yes or no. And that's a very difficult question, because in one hand, once you take these medications, you're going to lose weight, but if you discontinue those medications, you are going to gain all that weight back.
Right.
So therefore, you become dependent on the drug. Secondly, when you lose such a large amount of weight, and drugs with Tirzepatide or the new mechanisms that people are using with the Semaglutide, you can lose up to 15% of your body weight. Part of that weight is muscle loss.
Yes, I will ask as a next question. Let me...
But just before that, maybe...
Yes.
So, since you are becoming dependent, I'm not sure that for obese individual who doesn't have any other disease, this is the right way to go. If somebody has comorbidities, for example, like sleep apnea, for example, like diabetes, for example, like heart disease, so those drugs not only reduce body weight, but also improve the comorbidity.
Right.
The sleep apnea goes away,
right.
The cardiovascular risk decreases, and the diabetes is improved. So those are situations which should be considered to use these medications. But just for lose weight proper, if there's no other comorbidities, I'm not sure that this is the right way to go.
Thank you. The next question is, as you know, some patients lose a very large amount of weight, huge amount of weight with these medications, while others lose much less. Why do people respond so differently with this medication?
Now, this is an important question, and indeed, it's in general for any medication, you would see a wide range of response to each medication. Even in terms of glucose lowering, you will see some people lower their blood glucose markedly, some a little bit, and some don't reduce at all. With terms of weight, the bottom line, nobody knows what exactly, or there's no proof or evidence to show what is the real cause for this big variability in the response. Mm-hmm. But there are different suggestions and hypotheses that people think about. One, definitely, I think that's for sure, is that people they think if they take the medication, then they will lose weight no matter what they do. Ultimately, we all have to remember that obesity and body weight regulation is energy balance. As long as you take more calories in your mouth than your body is using, that means you are going to gain weight no matter what you do. Even if you take the medication, even people after bariatric surgery, they cut their stomach, and if they continue to take calories, they will not lose weight. And same thing here, and I have such patients who take these medications, but they have a weakness, keep eating sweet and chocolate and all kinds of calories, and they wonder why they're not losing weight. The drug itself doesn't make you lose weight. All the drug does, it shuts your appetite and make you eat less. But you can overcome that if you decide, I want to eat. Now, assuming that people are not overcoming the drug effect, the drug works in the brain. Mm-hmm. And in order to suppress appetite. But we inject the drug into the subcutaneous area, the fat underneath the skin, and from there the drug comes into the blood. And between the blood and the brain, there is a barrier that's called the blood-brain barrier. Not everything in the blood comes to the brain. And what I think is there is also some variability between different individuals by the amount of the drug that enters from the blood to the brain in order to suppress appetite and causes the weight loss. And the proof for that is that there has been a drug which is similar to Ozempic. It's called Abdul-Ghani, in which the drug was bound to albumin, which is a big protein and doesn't penetrate the brain. So that drugs did all of the good things that the GLP-1 receptor agonists are doing. It improves blood sugar, it reduces risk of heart attacks, but it never caused the weight loss. So the penetration to the brain is critical in order for the drug to cause a weight loss. And if there is different variability between the different individuals, you may also expect the different rates of response in terms of weight loss between different individuals.
Abdul-Ghani produce comparable result regarding glycemic control.
About the same, yes.
But there is no weight loss effect.
And it also reduces the risk of cardiovascular.
It doesn't cross
the blood-brain barrier.
Yeah, blood-brain barrier. Okay, good. The next question. Recent studies show that these medications can reduce heart attack, strokes, and cardiovascular death. How important was this discovery for diabetes and obesity treatment?
Oh, absolutely. That's a game changer in terms of diabetes, because our diabetic patients have a very high risk for heart attack, stroke, and cardiovascular death. Actually, 80%, the vast majority of our patients are going to die because of the heart or the brain, heart attack or stroke. And for many years, we were frustrated because we thought that because their blood sugar caused this increased risk. But when we did studies to reduce blood sugar in order to see the effect on heart attack and stroke, it didn't influence. So we didn't understand why is that. So this effect of these medications is by reducing the risk of cardiovascular, this is a game changer. The other thing is, we know that there are many cardiovascular risk factors for cardiovascular disease, even in people without diabetes, like blood pressure, like cholesterol, like smoking, like all of other risk factors. Now, what's unique about these studies is that all of these risk factors were optimized in the patients before they entered the study. So the cholesterol was reduced to where it should be, the blood pressure was reduced to where it should be, the glucose was fairly controlled, and smoking were the same, and everything, people were treated to the best that cardiologists could treat them. And on top of that, when these drugs were added, they caused additional reduction in the risk of cardiovascular disease, which is somewhere between 15 to 20%. And that is remarkable. That means that this drugs in a novel mechanism, in a new way, it reduces the risk of cardiovascular disease that we didn't know before about, and no other drug is doing. Unfortunately, we still don't understand exactly the mechanism, but as a clinician, it doesn't make much difference whether we understand or not, as long as the effect is beneficial and patients are enjoying this effect.
And one thing to add what you said, ADA, American Diabetes Association guidelines recommends that if someone has diabetes and established cardiovascular disease, what's the first line therapy?
Oh, that
almost.
I mean,
yes.
This is now, I would say, different, even stronger. If you have a diabetic patient who already has a cardiovascular disease, and you don't, and he's tolerating these drugs, and you don't give it to him, it's almost malpractice.
Right.
This should be the first drug
first line therapy
that you can give it to a patient, diabetic patient who already has a cardiovascular disease. This is now becomes the ABC of treatment, of management in people with diabetes.
Great, thank you. And do you think the heart benefits of GLP-1 based therapy are only related to weight loss, or do these drugs have other important metabolic effects as well?
I almost can tell you certainly it's not related to weight loss, because we just now, as you know, completing a study that we are gonna did analysis for all of these cardiovascular studies, and the magnitude of change in body weight did not relate at all with the improvement in cardiovascular. For example, I just mentioned the alba-glutide, which doesn't cause any weight loss, but it reduced by 20% the risk of heart attacks. Likewise, tirzepatide, which causes a massive weight loss, up to 20% of body weight. Actually, in the study, it caused 12% reduction in body weight. When it was compared to dulaglutide, that caused only 4% reduction in body weight, there was no difference in terms of improving cardiovascular risk. So the relationship between the weight loss and the cardiovascular benefit is not there. So that tells us that there is additional mechanism that we still don't know it, by which the drug is influencing the cardiovascular risk. Now, one more thing is that if you look into the longer studies, actually the benefit didn't continue after 3 years. So that's something that we don't understand. It tells us that the drug is doing something. There are some people who think mechanistically, for example, that it's due to a reduction or inhibition of inflammation, because these drugs also inhibition of inflammation, and inflammation, people think it may play a role in the development of atherosclerosis and heart attack and stroke, but that's just a hypothesis. Another surprising thing that you don't understand, for example, you would see that the reduction in the risk of stroke much greater than the reduction in the risk of heart attack, although both are due to atherosclerosis.
Right.
Why is it influencing the brain more than the heart? That's another unknown observation that we see. But again, as I said, even if there are some things that we don't understand, if they are benefiting the patient and the result is good, let's have them.
Yes. You know, newer medications such as Tirzepatide seem to produce even stronger effects. are we entering a new era in obesity treatment? And additionally, given the huge effect of 3G, retatrutide, GIP plus GLP-1 plus glucagon receptor agonist.
I mean, we are now witnessing a really tsunami or explosion of these drugs in terms of number of drugs that are developed to reduce body weight. At least I can count 10 or more medications under clinical development now in different stages for different mechanisms, whether they are working on GLP-1 alone, GLP-1 with GIP, GLP-1 with GIP with glucagon, or with amylin, or with other receptors to reduce body weight. The common for all these medications is that they suppress appetite and they produce large amounts of body weight. For example, you mentioned retatrutide, they can reduce up to 30% of body weight. That's a magnitude that we never achieved it before. The only way to achieve it is just with bariatric surgery, either bypass or sleeve. So here you can achieve the same amount of body weight without the bariatric surgery. Now, the other development in these medications is that now there are small molecules. All these drugs that we were talking about, the GLP-1 receptor agonist, are peptides that need to be injected. Whether weekly, at the beginning we were injecting daily, now we have weekly. Very soon we're going to have monthly injections. But all of these peptides need to be injected. But another development is that there are new novel small molecules that were synthesized in the lab, and they can be given as a tablet on a daily basis that can produce similar effects to the injected peptides. Mm-hmm. Now, the concern that one has to think about when using these medications that cause so much weight loss is that not all of the weight loss is a fat loss. Mm-hmm. But let's say take Tirzepatide or retatrutide that can cause 20-25% of reduction in body weight. About 1/4 of that is a muscle mass, and that's no good because that will make you more weak, especially if you are elderly, who is suffering from a loss of muscle, a process called sarcopenia, which is very common. And I personally see that in the clinic, especially in the elderly patients. When I give them this medication and they lose that amount of weight, they start to complain, "Doctor, I cannot walk. It's hard for walk. It's hard for me to lift things. I cannot do the things that I used to do before." And this is a concern that we need to think about it and to adjust the dose. That's what we can do now. But there is also one development in this field in that the companies are looking into other drugs that can preserve the muscle mass or can stimulate the growth of muscle mass. And the hope is that by combining those agents that can stimulate muscle growth with those weight loss medications, you can accelerate the fat loss without causing any additional muscle mass loss. But this is still experimental, and hopefully this will be safe and will soon come to practice, to clinical practice, that we can use it to patients and they can enjoy these medications.
One of the biggest obstacle for the GLP-1 based therapy is duration of the treatment. One common question from patient is, will I need to use these medications for life? What do we currently know? What's stopping treatment?
That's why I was alluding to at the beginning. Basically, if you look at obesity and overweight, it's overeating. And why people overeat is simply we need to eat in order to live. But we also enjoy food. Food is a pleasure. And there are some people who we can call them addicted to food, overeat even though they don't need food for their life. And therefore we can look at obesity as some sort of food addiction. Now, if you want to go to use these drugs in order to reduce body weight, as I said, it suppresses your pleasure of food and make you lose weight, suppress your appetite and make you lose weight. But then if you discontinue that, you're going to regain that weight back. So therefore you become dependent on the drug or addicted to the drug. Right. So I switch you from being addicted to food into addicted to drug. Well, you have to choose which addiction you like. At least addiction to food is more tasteful than addiction to the drug. That's the major problem.
Yes.
You need to continue to, as long as you take those drugs, it will suppress your appetite. But if you discontinue, you're going to regain that weight back. And that's something, this is why we need to educate patients. Unless you make switch in your head and you change your lifestyle in a way that you your expenditure of energy will equal to what you are taking into your mouth, you're not going to tackle the problem of obesity and you're not going to lose weight. And that's something that we need to educate our patients into it, because otherwise we're going to lose this battle for fighting obesity and diabetes subsequently.
Right. And misconception is contagious, and there is really big misconception about the GLP-1 based therapy. Many people believe that it's related to pancreatitis, some kind of cancer, and some serious side effect. Could you please summarize its side effect?
Yeah, most of the side effects for these medications are acute, usually in the gastrointestinal tract. Mostly nausea, can be vomiting, can be abdominal pain, diarrhea or constipation. But luckily, those, even though at the beginning they are common, up to a third of the patients can suffer from those side effects. We can overcome this by starting the dose in a very low and then escalating the dose slowly. Now, for any drug, certain percentage of patients, 2, 3, 5%, cannot tolerate the drug, and therefore we discontinue the drug. But as for the long-term complications, there has been some suspicions about pancreatitis, but as I said, when we did the cardiovascular studies, outcome studies, thousands or tens of thousands of patients were treated for several years, and none of those studies observed any increased risk in pancreatitis versus patients who were taking placebo. Same thing with cancer. There was no increase in the risk of cancer. So those cardiovascular outcome studies, although primarily were designed to provide us information about the effect of the drug on the heart and the stroke, they provided us with such a huge information about safety of those drugs, and they ensured again how much those drugs are safe, and they are almost free of side effects. And the first GLP-1 was introduced almost 20 years ago, and so far we are not seeing any increased risk either nor in cancer nor in pancreatitis. So I'm not concerned about these long-term chronic complications or bad diseases that, like cancer and pancreatitis, that people may think that these drugs are increasing the risk. So therefore I would say, if you can overcome the acute gastrointestinal complications that the patient may suffer from, those drugs are their benefit is by way outweighs the risk of having other unwanted side effects.
And final question, what is the most important message you would like to the public to understand about this treatment?
If you have overweight or you are obese without any comorbidities, my recommendation is to make change in your head, that to change in your lifestyle, that you can exercise more, eat less, and this way you can lose weight. And that's the best way, the cheapest way, free of side effects, and very effective. Now, if in addition to obesity, you have other comorbidities, as I said, like diabetes, like sleep apnea, like cardiovascular disease, I would recommend those medications. People with diabetes, to my mind, that should be one of the first drugs to be used, whether people have cardiovascular disease or they don't have cardiovascular disease. People who have cardiovascular disease, it becomes mandatory because it not only control his blood sugar, but it also reduces his cardiovascular risk. But even those who don't have cardiovascular disease, this drug should be the cornerstone on which you build the glucose lowering therapy in order to maintain that the glucose is maintained at the normal level, because maintaining the glucose at normal level in people with diabetes is also very important in order to protect the eye, the kidney, and the nerves. Yes, it doesn't reduce the risk of heart attacks, but it protects your eyes, your kidneys, and your nerves. That's also a very important goal in treating people with diabetes. So my message is, if you have diabetes, preferably, and you tolerate these drugs, ask your doctor to be on them, whether you have cardiovascular disease or not. If you are just suffering from overweight or obesity and you want to fight obesity without any other comorbidity, I think first you should make the effort in order to control your body weight just by changing your lifestyle and not relying on the medications.
Thank you very much, Professor Mohammed Abdul-Ghani.